to look at machine learning and AI. This is a topic I'm exactly super comfortable or familiar with. It's something that I've like touched upon in my statistics background, but isn't something I've really done a lot of work in. The closest I've done is survival analysis, which I will talk about in relation to this later. But I realize this title actually doesn't make any sense anymore in a certain way, because AI is actually very separate from machine learning is what I've learned. I didn't realize how separate they were until I kind of started going through this. But we'll talk about all my new information as we go through. So moving on. So I have three kind of main objectives for this lecture. So the first is kind of the fundamentals of machine learning themselves, because I imagine most of us don't really have a strong background in that. And it's a pretty good place to start. And kind of the paper I focused on, while it is a meta-analysis of a lot of different studies, it really was kind of an introduction to machine learning in the context of healthcare and research. Secondary objective, learn how we can use machine learning specifically in cancer susceptibility, recurrence, and survival. And then third, the implications of kind of everything I talked about before in general disease prognosis / what can we do to improve the process, what's working, what's not. So yeah, and if there's any questions, obviously stop me at any point. So first, we're going to start with what is machine learning. So it is a subset of AI where the algorithms use statistics. So this was kind of confusing for me to understand, because I figured that everything was kind of statistics at the base point. But the key difference here is this idea of kind of using probabilities versus, you know, things like if then. Obviously those are situated in probabilities, but there's a very large difference between kind of nesting your algorithm in probabilities versus more qualitative measurements, or depending obviously on what kind of sector you're working in, you know, there's other ways you can go about making an AI. Then deep learning, I kind of want to figure out what that was in the context of all this. And that is specifically using neural networks in a very layered fashion. And I'll go over kind of what a neural network is later. And I wrote here the capacity to learn. That is kind of a misnomer. So it kind of mimics the idea of human neural networks about how we like create these new maps and things like that. But it's more in a visual sense of, okay, if we have these kind of points in a diagram, we can kind of create these mini maps in between, rather than it's organically learning or something like that. Though that is an aspect that a lot of people use deep learning in conjunction with. So going to this core idea of we have a machine and we want it to kind of do something. We have a couple of ways we can train it to do that. There are three main ways I've listed here. The first one is supervised learning. And this is kind of like very objective. Like I have a dog and I'm telling you, go find this, you know, treat. And it's very clear about what that is. The goal data is labeled, and I don't mean that in a superficial sense. I mean that there's a distinction between labeled data and not labeled data. So labeled data is something we've kind of made a distinction about. So for example, it's like you have a picture and you're trying to figure out, is this picture a horse or a pig? And you've set this label for, oh, it is a pig or it is a horse. And that's something that someone kind of has to do. It's not necessarily inherent to the picture, right? The picture is just a bunch of pixels. The pixels don't have information about whether it's a horse or a pig. We have to assign that label to that. And that is what this labeling is. And when you do supervised learning, you have pre-existing label data that you train it on to say, okay, this is a horse, find. Unsupervised data is kind of almost the opposite of that. They definitely aren't exactly in parallel, but the idea here is you have pretty much you have no label data. You don't have any horses or pigs, but the machine can be like, oh, these pixels look pretty similar. I'm going to assume this is one pattern and this is another pattern. And those end up being the pig and the horse, for example. Then finally, reinforcement. I didn't get a lot of information about this from the MIT resource that I used specifically, and it was kind of hard. Everyone kind of has a lot of different definitions for all these types of learning, but reinforcement kind of falls in between, but is not exactly what I'll later talk about is semi-supervised learning, which is a very balanced in between. Reinforcement, I think, is kind of like we have both labeled and unlabeled data and we're really not sure what is working best. So we're going to kind of just try looking at both. And that has its own set of issues, but I'll kind of talk about these in the context of a machine later towards the end, because right now I'm going to go mainly into supervised data because that's what, or supervised machines, because that's what we mainly work with. Down below, I have a little figure right here. These are all the figures I have in the article or in this presentation are from the article. And this one specifically is talking about supervised learning, where we have tried to classify a tumor as malignant or not malignant based on their size. And again, this is one of those things that'll make more sense when we have a better understanding of what a machine does. But right here, we can see these ones that were a little bit larger were mostly considered malignant, though there were a couple that were misclassified, and then same for the other case. So moving forward, why machine learning? Obviously, it's kind of obvious at its core that it's, you know, it's more information to work with. It's less that we have to do on our end. It's, you know, something that we can kind of get automated to a certain extent. But kind of going to more specific healthcare reasons why this might be useful, we have the idea of performing personalized care, which is a big movement in healthcare right now, where we adapt further to a patient's context, both in socioeconomic status, both in their existing health conditions, in the context of what, you know, that institution may be able to do. There's a lot that you can personalize there. And if, you know, at the end of the day, if a machine is able to further assimilate what your institution can do versus what may be the gold standard or what other larger or smaller institutions can do, it immediately helps you better understand your capabilities as providers. The second is it utilizes already existing research, which means half the work is already kind of done. Genomics, imaging, you know, cancer immunology, all these research is like compiling data. Almost all institutions keep track of the data anyway for usually retrospective analysis. And this basically just further utilizes that in, you know, a more exciting way, for lack of a better word. And next, so kind of showing what it's already done, it has bolstered the accuracy of cancer prediction outcomes by about 15 to 20% in the last few years alone. Machine learning has been pretty much something of the larger part of the last decade. A lot of the techniques and technologies I'll be talking about were formed closer to the end of the 90s. So it is really new, and that means it already has such a large kind of potential gap between where we are right now and what it can get to. And, you know, kind of obviously speaking, if you know where your cancer is going or your disease prognosis is, you're obviously able to make better understandings of what treatment is possible, can reduce the anxiety of the patient and the doctors. They don't have to worry about necessarily like, oh, I'm doing something wrong here, or what if I'm missing some objectives? It immediately just minimizes the amount of uncertainty, which obviously makes humans just happier and more secure. So, all right, so ideally you're on board now. Ideally you want to try it, but how do we do that? So we're going to start by obviously looking at what we want to predict. The machine needs a goal. So I'm going to talk mainly about supervised research again. So this is mainly classification problems. It's like going back to what I talked about the malignant tumors. Is a tumor malignant or not? That's a classic classification problem that's in cancer research that's being done right now, and that is usually the typical outcome factor, but this could often lead to also, you know, how long is someone going to survive? Is the cancer going to come back? Those are all things we can classify, and that's something we have to kind of decide beforehand, and needs to be really based on research, because obviously size is something we understand may be related to malignancy, but if we're looking at a subtype of cancer where that might not be as good of a predictor, we need different predictors. So leading into that, we need predictive factors. So what can we use to predict our outcome? So this again is based in research, but it's also something that we need to be careful about. So I wrote here gathering and culling data. So normally having a lot of data is really important. It is really useful to have a lot of starting data. But when it comes to machine learning, again, imagine this is like a person. If you're trying to make predictions, it's really hard to keep all this information in your head. And when we have too much information, that actually generates a lot of noise and makes your model almost too specific. And then generalizability is something really important / you know, having a robust model. So dimensionality, for lack of a better word, is just kind of saying how many variables you got. And then feature selection is similar to that, but is a bit more algorithmic in the fact that you have a data set, you want to choose specific features, or you might want to take a subset of features and compile them. You might want to do the opposite and expand a certain feature. There's a lot of ways you can kind of go about working with dimensionality, and that kind of ties into some other different methods that we can use as well. And then obviously, is your source data quality? Is it unbiased? Is it representative of your population that you're looking for? Machine learning isn't really about referencing, or sorry, not referencing, but inferring. You're often looking at, like, again, things like classification, outcomes, and inference isn't something that is necessarily powered for just yet, but it is something that's kind of in the works. But obviously, I mean, you all pretty much have done research before. You know how bad data collection can be, especially in healthcare. You know, there's people who really don't understand the importance of data entry. And that's something that's really important to take into account when you're looking at how you can apply this technology. Is like, is my institution a place that has collected good data? Is that something that works? Or is there already a database that we can use that really is applicable for our, you know, pool of what we're trying to apply it to? And then afterward, we can, when we have our model, we have to obviously assess it. Is it a good model? Oftentimes you'll separate a training data set from a test data set. So you'll have a certain data set that you use to train your model, and then one you use to simply see if it's actually working well. And then you have a couple other methods where you can like minimize your features. So specifically going through this list I have right here, the holdout method is what I just said, is you're separating into training and test data. And then you actually make something like a calibration model afterward based on, you know, pure statistics. And then you kind of see, oh, how does it compare? And what I have on the left here is what someone has done. This is technically a holdout model because it uses a sense of a calibration. But basically here you have sensitivity on one scale and then 1 minus specificity. And here what you're looking to maximize is you obviously want, for when someone has the disease, for you to be right, and for when someone doesn't have the disease, for your test to say they don't have it. So that accuracy, in a sense, is compiled by this area under the curve, and that'll be labeled as AUC later on. And then this line right here is simply basically a 50-50 guess. It's like, oh, I'm randomly guessing. What does that look like? Obviously, the area under this curve is larger than this, and that is effectively saying it's a more accurate model. Random sampling, you're basically taking your model, taking subsets of the features that you're using, the types of data and variables, and then basically seeing how accurate each subset is and seeing how that works. And then cross-validation, it's very similar, but in this case, you're kind of methodically looking at different subsets of the data versus randomly sampling subsets. And then finally, bootstrap. This one is a little bit more confusing to me. Basically, the distinction between training and test data sets are a little bit blurrier. Basically, you would do a training subset of a big data set, and then you put it back in and then do the entire thing as like a testing. So there's a bit more like kind of combining of the two. I'm not really understanding how that affects accuracy, but obviously I'm sure all of these have kind of certain specs for when they're best used. So going on more specifically, so these are specific types of supervised learning that we can use. So there are 4 models I'm going to talk about today in specific. The first is the neural network. This is what is composed in deep learning specifically. This is pretty common. The origin was in the 40s, I think, of when this kind of started working, and is modeled again to how our brains work. And you can kind of see with this little diagram down here, basically the idea is you have your input predictor variables here, and what it does, it basically maps in between to create almost like a transformation of these variables, saying like, depending on how much we can weight things, obviously, you know, certain aspects like age are really important in cancer, you know, things like smoking status. So obviously those would be input variables, but those would be weighted differently in the calculations, and that's what this hidden layer is about. And then once these hidden layer calculations are done, you get this output layer of what, obviously your outcomes that you're looking for. What this kind of has this issue with is that you do have this kind of mishmash. It's really powerful being able to mix all these different nodes of your predictor variables, but it's really hard to go back and troubleshoot and see how those all work together. So it's really robust, definitely has a lot of power, but if you're trying to go back and really make small changes, it's a little bit difficult. And that kind of falls back into the second one too. Also lacks the robustness in a certain sense, but in a different way. So the decision tree is what you often see as a typical probability tree. You're kind of just going by and seeing, how we can verify a variable. So we have X variable, and then it goes into, male and female, and then it goes into smoking, not smoking. And this is really nice because you can really pinpoint where each thing is going towards versus, this nonsense that's happening here. But issue is, if you're changing one predictor variable at the top, it obviously impacts a lot of things further down the line. So if you want to go back and kind of modify your model, there's a lot of like small changes that will obviously kind of lead to chaos towards the end of the reign. And with simple models works really well. The more complex it gets, it's nice for really identifying where you might be leading to like some like high variant kind of variables. But if you're really trying to get an accurate model, kind of a little bit more difficult. Any questions about those two or anything thus far? Sounds good. So next two. The first one is called the SVM for short, support vector machine. This one took a while for me to wrap my head around. So hyperplanes are effectively subsets of a higher dimension. Wow, that makes me sound smart. So you have the 3D world. A hyperplane of the 3D world would be a 2D world. So it'd be, if you have a 3D space, it's the X and Y plane. Those are the hyperplanes of the 3D plane. Hyperplanes of a 2D plane would be a line, so on and so forth. It's really just saying, take the derivative in a certain sense. But obviously this gets more complicated when you have a lot of different variables, because then it becomes, you have 7 predictor variables. You're talking about the 7th dimension. But that makes it really powerful in a certain sense. This is definitely one of the newer methods, and it's still kind of in development, but it's so far being a very, very strong source of, power in determining boundaries. And a simple example is down here. You have age and tumor size as predictors, and then using this hyperplane here, we've figured out a boundary to make a difference between malignant and not malignant, as per like that first example I used earlier. Obviously, there's more here than there was in that flat line a couple slides back. But obviously there's still some misclassification. But again, these are 2 variables, and it's really easy to kind of ramp this up to multiple. What this doesn't provide nearly as well is probability. So in this case, it's saying, okay, I can classify pretty easily, but I really couldn't tell you the probability of, this selection being malignant or this selection not being malignant. What, a counterpoint to that, our counterpoint model is the Bayesian network. So Bayesian statistics are effectively a more robust version of looking at conditional probabilities, where, if then, that's a basic probability statement right there. That's Bayesian, that you can break down into a really robust set of statistics that you can use. And that is really useful when you have a lot of information about what you're working with. So if you have a lot of research in the domain already about what your predictors are, how much of a variance they may cause in the model, this is really useful. So here, this is kind of complicated. It's really not easy to explain what Bayesian statistics are if you haven't experienced it before. But the idea is that you're able to know each set of probability of what's happening here. So probability of C, no, yes, we have that information. Probability of no, yes, for like variable A, we have that as well. We have that for all these different types of variables. So this really, in a sense, is really one of the strongest when you know a lot, but again, not as really robust in the sense that if you don't have a lot of information, it really can't predict as well. So kind of almost logistic in how much power it has. And those are the main four models that this article kind of goes into and kind of analyzes in the grand scheme of cancer research. So kind of going back to that, back to cancer. So three different variables, I suppose, that are really important to figuring out a cancer prognosis are susceptibility, recurrence, and survival. And I have these definitions here. Obviously, susceptibility, the chance that you're going to develop a type of cancer; recurrence, chance that the cancer at its local state will come back or can be controlled, so forth; and then survival, recurrence on a more larger scale. If you get remission, what are the chances it's going to come back overall? Knowing these different variables gives information into life expectancy, survivability, progression of a disease, and obviously sensitivity to different types of treatment. So we're going to go through each of those and look at a model article that this main article chose. So this table below goes into detail 5 different studies it looked at that use machine learning to develop a model for cancer research in terms of susceptibility in this case. So the one I chose was this first one right here, mainly about finding breast cancer in a set of women, I believe. Well, obviously women, but specifically women in this case. And we're looking to see how we can distinctify malignant tumors from benign tumors. Pretty simple case here. What this model that was really interesting was it really focused on a couple of key predictor factors. So we have demographics. I think they were very, very, very minute. They were, I think, just race and age. And then mammographic characteristics. So this is something that is important to note here. They used something very intrinsic to the outcome they were looking for. And that gives it a lot of power in that sense, but it's also something that you may not necessarily have a lot of information about all the time for your population. So in this case, for how they wanted to also determine how well they were doing, they were mainly looking to see how well they were discriminating, so separating benign abnormalities from malignant ones. And then they also did some work on calibration. So going back to that ROC curve I pointed out earlier, they applied a calibration curve. For lack of a better word, is basically saying, okay, we have a model, how can we kind of calibrate it at certain points to make it more accurate to a more general population? So, and what they wanted to do here was, again, focus more on risk assessment rather than just necessarily, figuring out, do they, benign cancers or malignant cancers. So some key outcomes here. As you can see, their area under the curve is very high, 0.965. The sample size is also really high. So this is pretty strong findings for this kind of study. And it really reinforced the idea that if you have these characteristics here, these are really powerful. They can really help you figure out, malignant cancers early on. So that's mass shape, breast density, and there were a couple other ones that were listed. The issue here is it was using that ANN, the neural network. So there is that high level of hidden layers. So I think they really focused on amping up that kind of black box mentality. So if they were to go back and try and modify this model, it's kind of difficult. And that's why I think they focused on that calibration curve, is that they really want to be able to use this model rather than go back and have to start over, because it'd be a lot of work. Then there were a couple other studies they looked at. You can see that, this study here used SNPs as a type of data, and they had different types of validating their data. This pretty much all of these use cross-validation, but obviously they use different levels of it. They, in this case, left one out, which was an interesting idea. I'm not sure exactly the benefits, again, of certain types of these validation methods, but I think it's really interesting to see how much variance you can get in these kind of experimental designs. Going on to recurrence. So in this case, the main model article was one that was looking at the recurrence of oral carcinomas. And here, the data they used for predictive factors were fairly heterogeneous. So they had a lot to work with, but they had to work a lot more on processing that data beforehand and really making sure that they weren't, necessarily overfitting their model. Main error analysis they were going to do was fairly simple. They were just going to be discriminatory about it. What they tried to do was use feature selection to better utilize the data set that I mentioned. So like I mentioned earlier, feature selection means that we have this strong data set, but we can further select the more predictive factors from it. Obviously, this is better done earlier on, but feature selection is kind of something you can do further into the study that lets you further make your model a bit more accurate. Main issue here is, while they may have at 100% accuracy rate, they did only have 86 participants, which is really poor in regards to how much data they had on them. And in this case, you really do want a balance of how many participants do I have and how much data on them do I have. Otherwise, you're going to get into this issue of my data is, really only useful for this population, which obviously isn't something you really want. They did actually use, so the one they had found to be the best and the one they got 100% accuracy on was the Bayesian network, but they did use multiple algorithms. And this is something that's pretty common across a lot of these. Most of these listed here are the main ones that they found were most accurate, but most of these studies are using multiple methods just because, again, this is research that is really so young in the grand scheme of things that finding the right tool is also kind of difficult. And that's why they're really trying a lot of algorithms. This isn't necessarily data dredging because they're not necessarily looking for, a significance. They're not inferring about anything about the population here. They're really using this as a diagnostic tool. So this is why it's a good time to actually try out all these different techniques before they try and make, leagues of like trying to develop ways to infer information about a population using this technology. Then finally, survival. So in this case, we want to figure out how many people are going to survive with lung cancer. Again, another study looking specifically at women. Predictive factors, these ones were pretty, and they didn't use too many. They used some gene expression data and then some minute clinical data. They used sex, age, T-stage, and end-stage information about cancer. And as far as the error analysis goes, they did something really interesting here where they use survival analysis. Is effectively the very core principle of like machine learning, I suppose. There's no learning here. You're really just making a bunch of probability statements and figuring out, oh, this is how many people I think are going to survive. So this is really the gold standard for survival analysis in general, this technique of survival analysis. And what they found was that it was fairly accurate. The issues here they had was that it was almost too specific. So again, their sample size was moderately sized. It was about 440. Accuracy was decent, but they didn't really have much information on death, which is kind of what they were looking for in the first place. But that's something that you often don't get a lot of. It's because obviously after death, you have to go through an autopsy. There's a lot of work that is go into getting that information about why the death happened. And obviously a lot of these people with cancer have a million other comorbidities that make it difficult to really get clean data for death-related variables. So that's why this is really specific to the non-small small cell lung cancer patients. But the main thing here was that they were able to really compare this to a more traditional statistical method here, and they found that it was working pretty well for them, which is really exciting. And this was a fairly new study. It was done in 2014, and there has been a lot that has been done in the last 6 years, but it's still kind of, very similar to this in that they're really trying out a lot of different methods, figuring out what predictive factors are useful, what aren't. So having said all that, I kind of talked about the limitations so far in the more mechanical sense, but I do want to talk about some more qualitative limitations here. So obviously it's expensive. You need strong computing processes. You need people who know how to do that. And obviously at the end of the day, this isn't going to be something you see in a lot of smaller clinics for a while. And especially when you're looking at more specific populations, if you have clinics that, are focused really on a lot of homeless people, there's not going to be a lot of data you can use on that from like previously made data banks. So you have to rely on your own data. which again kind of can be costly if you have to do your own data analysis. And then going back to what I talked about earlier about reducing anxiety, it can still pose issues of overwhelming patients to a certain extent. This is just statistics in general, obviously, but it becomes a little bit more real when you have a machine tell you, per se, or you have the sense that, oh, it has done the work to provide this accurate estimation or prediction. So the burden of knowledge here is obviously a lot, because you no longer can simply say, oh, I think this is going to happen. I'm going to, focus on preparing for this outcome of the disease. It's, oh, we have 60% chance of this, 40% chance of this, and then like a 1% chance of this. I really have to make a choice here, but now I have almost too much information. Like, how much resources do I put into each of these versus just believe in my own diagnosis as a doctor, or so on and so forth. Then data specifications. This goes back to what I talked about earlier. Most data in institutions are trash. So data processing needs to be really thorough to get this to work. And again, you need to have biased or unbiased data, not biased data, and then representative data for what you need to do. So the future of machine learning versus disease. So obviously things are looking pretty good. Things are accurate, but things that need to improve are experimental design. So obviously we've seen a lot of design where there's not enough sample size. There is a lack of an understanding of what model might work. And even though it's not a traditional statistical analysis, obviously, in any case, the more tests you do, the more likely it is you're going to get a random occurrence that is good due to chance. So really honing down what is good experimental design in the context of machine learning is really important. And that ties also back to getting better data collection. Also mentioning before, I mentioned that neural networks are pretty old. I also mentioned that decision trees were fairly simple. The ones that kind of need the most work right now are SVMs and Bayesian networks. The support vectors, obviously, really new, so it just needs more work to figure out how to better use those and better understand higher dimensions, for lack of a better term. And then Bayesian networks. Bayesian statistics is very well researched, but again, the lack of robustness makes it hard to use. So finding ways to, further calibrate it for that, middle ground where you do have a good knowledge of the conditional probabilities, but not all of them, that'll be a great place to work on for better risk assessment. Then we have better integration of data types. So I talked about heterogeneous data earlier. It's really great when you can have all this different type of data. It does become difficult to choose at that point. So really learning what data types we need for certain types of research / using data that is pretty new. We'll be talking about imaging, in a week or two. But that's data that's also pretty new in the grand scheme of things. Proteomic data, so protein related data, that's also fairly new. And that's something we can better learn how to use. And then finally, going back to what I talked about at the beginning, what I've been really talking about, supervised machine learning. Unsupervised machine learning obviously just isn't very powered. There is a lot of potential there, but really most of the potential here is in semi-supervised machine learning, which again is kind of bringing in both labeled and unlabeled data and really finding a good balance between, we can find patterns and classify information. The unsupervised machine learning almost ties closer to AI, which is why I think that my title isn't accurate anymore, because finding patterns is something that is really hard to do from a statistical standpoint, and is more reliant on that artificial intelligence aspect of things of, this machine needs to kind of learn on its own, which is not my field by any means. But yeah, that really help in minimizing data processing, because labeling data is really expensive, because you can't have that intern go through all your pictures and say, oh, this is a horse and a pig. That's just not viable. But yeah, that is pretty much all I had regarding machine learning in the context of cancer / some of it in disease in general. I think there's a lot to work on here, but it's really exciting because this is definitely, obviously, one of the most new forms of research that there is right now. Obviously, there are some fears about research into artificial intelligence. I still have my doubts. And this honestly made me realize that we're further along than I thought in getting to really strong ways of I don't know if y'all seen videos of deep learning, but it's pretty wild. And like reading about it and seeing how much was progressing in the last couple of years, it's kind of scary. But yeah, that is my presentation.